Good morning, everyone. I am Vidhi. Good morning, everyone. I am Vidhi, presenting the topic of metadoxin and silymarin under the guidance of Dr. Ayush. Metadoxin, it is formed by salification of two components, PCA and pyridoxal. It is used in acute alcohol intoxication, alcoholic fatty liver, alcohol withdrawal syndrome, chronic alcohol abuse. It improves insomnia, anxiety, mood, and thinking disorder. It is used in supportive treatment of acute and chronic liver disease. Metadoxin has multifactorial mechanism of action. It increases GABA and acetylcholine release, thus increasing glutathione. It reduces hepatic fat. It potentiates reduction of insulin. It reduces stress, anxiety, and depression. It is an powerful antioxidant. It decreases oxidative stress, restores glutathione production. It protects membrane and integrity of hepatocyte. It decreases lipolysis, increases activity of acetaldehyde dehydrogenase, and increases hepatic ATP content. Dosage. For alcohol intoxication, dosages 500 to 1000 milligram orally or 300 to 600 IV or IM daily. For alcoholic fatty liver and supportive treatment of acute and chronic liver disease, dosages 1000 milligram orally or 300 milligram IV or IM daily. It has less side effects like skin rash, diarrhea, dizziness, decreased appetite, stomach pain, and nausea. It is contraindicated in pregnancy and used cautiously in while lactation and in elderly. It is not used with alcohol and not used in allergic conditions. Metadoxin decreases the effect of levodopa. Silymarin. It is extracted from milk thistle seeds and it is used to treat hepatic conditions. It has low incidence of adverse drug reactions. Uses. It is used in fatty liver disease, acute liver failure, alcoholic cirrhosis, and diabetes. It has protective effect on erythrocyte lysis and cisplatin-induced acute nephrotoxicity. It inhibits apoptosis and follicular development in patient undergoing IVF. It has preventive effects on breast cancer, ovarian cancer, and lung cancer. Mechanism of action. It acts as a free radical scavenger and modulate enzyme associated with cellular damage, cirrhosis, and fibrosis. It reduces oxidative stress. It is used as blockade and adjusts cell transporters, P glycoprotein, estrogenic and nuclear receptors. Dosage. Adult dose for hepatoprotection is 420 milligram per day of this extract TDS for 6 to 8 weeks and maintenance dose is 280 milligram per day. Its acceptability is good. It has few side effects like allergic reaction, GI disturbance, nausea, headache, joint pain. These are the references. Thank you for patient listening. Good morning, everyone. Today, I, Aparna Saklani, is here to give a presentation on heart block. Electrical conduction system of heart. SA node generate the impulse for the normal rhythmic conduction throughout the heart, and it travels via internodal pathway to the AV node, and from there it travels via bundle of hairs to the left branch left branch of bundle of hairs and right branch of bundle of hairs, and it travels to the Purkinje fiber. Normal electrocardiograph. It presents P wave, QRS complex, and T wave. P wave indicates atrial depolarization, and QRS complex indicates ventricular depolarization, and T wave indicates ventricular repolarization. The PR interval is the PR interval indicates AV nodal conduction and is usually less than 160 milliseconds. And the QRS complex is 100 millisecond and QT interval is 360 millisecond. The definition of heart block, it is known as the AV block, in which the electrical signal that controls your heart is partially or autonomic causes, carotid sinus hypersensitivity, vasovagal. Metabolic causes include hyperkalemia, hypothyroidism, hypermagnesemia, and drug-related causes include beta blockers, calcium channel blocker, antiarrhythmics, and infectious includes endocarditis, tuberculosis, syphilis. Congenital causes for AV block are congenital heart disease, maternal SLE. Acute MI also cause AV block. Infiltrative causes include amyloidosis and hemochromatosis. Catheter ablation and radiation also causes AV block. Types of heart block. They are further classified as first degree heart block, second degree heart block, which is further classified as Mobitz type 1 heart block, Mobitz type 2 heart block, and third degree heart block. First degree heart block. First degree heart block is slowing of conduction through the AV junction. The site of delay is typically in the AV node, but maybe in the atria, bundle of His, or his Purkinje system. In this, there's prolongation of PR interval beyond 0.2 seconds. It rarely causes symptoms and does not usually require treatment. In this, we can see that that the PR interval is more than 0.2 second. So this can be a case of first degree heart block. Second degree heart block, Mobitz type 1 heart block. In this type of heart block, the problem is within the AV node itself, and thus some impulse fail to conduct to ventricles. This serial prolongation of PR interval, shortening of RR interval, resulting in a drop beat. This phenomenon is known as Wenckebach phenomena. The ECG complex after drop beat exhibit a shorter PR interval than that immediately preceding the drop beat. Mobitz type 2 heart block. In this type of heart block, the PR interval of the conducted impulse remains same, but some of the P waves are not conducted. This is usually by the disease of the His-Purkinje system. Occasionally, a drop beat can be seen. In the first diagram, we can see that the PR interval is serially prolonging, and then a drop beat is seen, and after which the PR interval is less than the PR interval of the preceding wave. And in Mobitz type 2, the PR interval is constant, and we can see a drop beat. Third degree or complete AV block. In third degree AV block, conduction fails completely through the AV node and atrial ventricles beat independently. This is known as AV dissociation. Atrial rate is 100 per minute, which is controlled by SA node, and ventricular rate is 40 per minute, which is controlled by a bundle of hairs. Cardiac output is drastically reduced due to bradycardia and lack of cooperation between atria and ventricles.
Clinical features usually include a recurrent syncopes or Stokes-Adams attack, regular and slow pulse. In this, we can see that the number of P wave is not equal to the number of QRS complex, and the PP interval is not equal to the RR interval. Thus, it is a case of third degree heart block. Management. Asymptomatic first degree or Morbus type 1 AV block patient usually does not require any treatment. Symptomatic second or third degree AV block may respond to atropine 0.6 mg IV repeated as necessary, or if this fails, a temporary pacemaker can be deployed. Patient with symptomatic bradycardia associated with AV block should be treated with a permanent pacemaker. Site of pacemaker's placement is left intraclavicular below the skin of chest. It is radiopaque and can be seen on chest X-ray. Now, Wolff-Parkinson-White syndrome. It is a condition characterized by abnormal electrical pathway in the heart that causes a disruption of the heart normal rhythm. It is a pre-excitation syndrome. The electrical signal bypass the AV node and move from atria to ventricle via fast accessory pathway known as bundle of Ghent. Contraction of partially filled ventricle lead to slow cardiac output, which can cause symptoms like dizziness, palpitation, fainting, and shortness of breath. Heart rate is increased, leading to decrease in the PR interval. In this, the heart rate is increased, so PR interval is less than 120 millisecond. Delta wave is seen, which is the upswing of the R wave, and Q wave is absent because the septal activation is not occurring as the AV node is bypassed. And so the QRS complex is narrow. Treatment, drug of choice is oral flecainide to prevent further episodes. Treatment of choice is radio frequency ablation. These are the reference taken.
Which is type 1?
So type 1.
This first degree. Is a normal PR interval there?
Less than 200.2
milliseconds. 0.2 milliseconds. 2 seconds. So if it is more than that, then we say it is first degree.
No, sir, we can validate.
Good morning, everyone. Today, the topic of my discussion is ursodeoxycholic acid. It is also called as ursodeol or 3,7-dihydroxycholine 24 acid.
Metadoxin?
No, sir. Metadoxin, maybe. Some basics about UDCA. It was first found in beer bile pulses, therefore called as ursodeoxycholic acid. It has a steroid nucleus with hydroxyl groups, therefore it is called a steroid acid. After oral administration, it is conjugated in liver with glycine and taurine to form glyco-ursodeoxycholic acid and toro-ursodeoxycholic acid. Here we can see the cholic acid and chenodeoxycholic acid are conjugated in bile to form secondary bile acids, that is methylcholic acid and ursodeoxycholic acid. This is the chemical structure. So here, the primary bile acids are cholic acid and chenodeoxycholic acid, which are also presented here. They are excreted into the small intestine via the gut microbe they are converted into lithocolic acid and ursodeoxycholic acid. They are called the conjugated bile acids or the secondary bile acids. This is the chemical structure of ursodeoxycholic acid. It has a steroid nucleus, and the difference between the lithocolic acid and ursodeoxycholic acid is the hybridization of this hydroxyl group, which is present on 7th position. The mode of action of ursodeoxycholic acid is it expands the bile acid pool and leads to production of more endogenous bile acids. It improves the hepatocyte redox reactions, therefore reducing the hepatocyte destruction rate. It stabilizes the epithelial membranes by the same mechanism. It inhibits the cell apoptosis, but it is still under trial. Not significant results have been found, but it is postulated that the conjugated acids, tauroursodeoxycholic acid and glycoursodeoxycholic acid, were able to modify the mitochondrial membrane perturbation, pore formation, the Bax translocation, which is the most important gene in apoptosis, cytochrome C release, and capsase activation, and therefore the subsequent cleavage is inhibited. It acts on glutamate receptors with prolonged therapy, which we will see further. The side effects of ursodeoxycholic acid are very minimal and usually seen in rare cases. It can cause pasty stools, diarrhea. Decomposition of cirrhosis is seen in alcoholic patients. A very long prolonged therapy needs liver function tests to be monitored, and it may increase the dopamine levels in the brain, which we'll see further. The contraindications for ursodeoxycholic acid are acute inflammation of the gallbladder, bile ducts, biliary tract occlusion, which we call as cholestatic diseases, frequent attacks of biliary colic, calcified stones if present, and if there is impaired contractility of gallbladder, and if there are active gastric or duodenal ulcers. The drug interactions which have been postulated are with cholestyramine, cholesterol, and antacids. It binds with them and limits their absorption. With cyclosporin, ciprofloxacin, antibiotics, it affects their intestinal absorption. With if given with rosuvastatin in the doses of more than 500 milligram per day, it elevates its levels. Since it elevates its levels, we need to monitor the blood concentrations. With dapsone, it decreases its effects. It induces the cytochrome enzyme P453A, because of which the drugs which are metabolized by these enzymes, the T-half is decreased. And if the females are on UDCA, they should use non-hormonal contraceptives, because with hormonal contraceptives, the risk of biliary stasis is increased. And estrogen and blood cholesterol lowering agents increase hepatic cholesterol secretions. Therefore, it is an antagonist for this drug. The dosages and uses. The main use for which we give UDCA is dissolution of gallstones. It is given in the dose of 8 to 10 milligram per kg per day, which is the usual dosage for 4 to 6 months. But if the lithogenic index of the bile is more than 1, the results are unlikely. For radiolucent, it is only used for radiolucent stones, which are not seen on usual X-rays of less than 2 centimeters. So we have to do contrast X-rays or ultrasound. If the treatment is stopped between the course for 3 to 6 weeks, it leads to oversaturation of bile, and therefore we have to prolong the treatment. For primary biliary cholangitis, there are 4 stages. For the first 3 stages, it is given in the dosage of 12 to 15 milligram per kg per day. And for the 4th stage, it is given half the doses, 6 to 8 milligram per kg per day. And if there are no derangement of the LFT, we can increase to the usual doses. For cystic fibrosis, the patient presents in the adolescent age of 6 to 18 years, and we have to increase the doses up to 30 milligram per kg per day. The Indian brands which are giving ursodeoxycholic acid are many. There are 53 brands, but some of them are Abbott, which is giving Udilip, Intas, which is giving Golbi, and Sun Pharmaceuticals, which is giving Ursocol, and Eris is giving ursodeoxycholic acid as Hepexa. There is a case study reported by Mohsen Khosrow. It is published on NCBI site. The case is the treatment of refractory schizophrenia treated with 300 milligram UDCA twice daily for 12 months. No side effects were reported, and appreciable results were seen in the patient's conditions. Conclusion was UDCA augmentation seems to be an effective treatment strategy for patients with TRS. but yet randomized control trials are to be done. So this was the process through which the doctor gone through. First of all, the clozapine was given, but it led to tremors, sleeplessness, nausea, sialorrhea. Then the patient was shifted to olanzapine, further to carbamazepine, lorazepam, propranolol for 2 years, but satisfactory results were not seen. Then glycine, serine, cycloserine, methyl glycine were also given, but they had no benefits, which are also called the novel agents for the treatment of schizophrenia. And then he resorted to metrazepine, increases the levels, but the LFT shot up. Ultimately, UDCA was given for a course of 12 weeks and substantial results were seen. The positive and negative syndrome scale changed from severely ill patient to mildly ill. The mini mental state examination changed from moderate to normal. The hypothesis given by him was it has neuroprotective and hemostatic properties. It has the capacity to inhibit glutamate release in normal microglia and microglia depleted hippocampal tissues. The therapeutic mechanisms for the same were found out that it reduces the tone of glutaminergic neurons, which then understimulate the GABA neurons. By this pathway, it increases the mesocortical DOPA pathway activation and DOPA release in prefrontal cortex. And so the negative and the cognitive symptoms were decreased. On the other hand, it reduced the firing of cortical glutaminergic neurons. Dopamesolimbic pathway was hyperactivated. Therefore, the positive symptoms were diminished. The other hypothetical uses of UDCA in psychiatry and neurological diseases are as follows, but it still needs evaluation and is only done on rats and guinea pig brains. So it was seen that in Alzheimer disease, it reduced the A beta production by toro ursodeoxycholic acid. It was also used for multiple sclerosis and Parkinson disease, as we see that the DOPA levels have been increased. The sources for the presentation were
Who has monitored this?
Dr. Sarthak.
Sarthak, very well done. Very well done, because you addressed the psychiatric part. That is why we go this. Who gave these topics? Very, very good topics. So, few questions are there. You're saying that dose is around 15 to 18 milligram per kg body weight. Yes. So how 300 milligram morning, evening generally we give? So how we justify 600 milligram?
Sir, 2 tablets of 300 milligram per 300 milligrams are given, and we can give single tablet
per kg per day. So that amounts to around 990 milligrams.
Yes. So single tablet is given in the evening, and 2 tablets are given at the bedtime with snacks or after the meal. Single tablet is given in the evening with the dose is 900 milligram, and 2 tablets are given at night with some snacks or
morning or evening.
Yes.
So you're saying the contraindications that biliary stasis, biliary stasis में नहीं देना है, then at the same time cholangitis में देना है. So isn't it really confusing? कम नहीं देना है.
Sir, in biliary stasis, I meant that if there is impaired gallstone contractility or if tract obstruction,
like obstructions है, gallbladder stones patient हम पता कैसे चलेगा?
Sir, after ultrasound, and we can see also correlate with the history given in the patients which have.
So when we use it in liver,
sir, when the gallstones are less than 2 centimeters in size, they are radial inside, that is, they are cholesterol stones. The main mechanism of action of UDCA is that it inhibits the reabsorption by the extrahepatic pathway, and it inhibits the reabsorption. 95% of bile is reabsorbed, and then it is against the circulation. Yes, sir.
Then it could result in flushing of and then थोड़ा सा अब हम लोग तो देते हैं बिलोरुबिन बढ़ जाता है.
Yes, sir. Sir, usually in the cases of jaundice, we see that, but sir, it has other mechanisms also. Like it inhibits the apoptosis of the biliary tract. It stabilizes the membranes by reducing the redox reactions. So,
That I understand. But here when patient would come, generally we give it because when bilirubin is at the higher side.
yes, sir.
So when the bilirubin higher side में stasis में भी हो सकता है, obstruction में भी हो सकता है. How you differentiate it?
So after contrast sections or ultrasound, we can see.
इसका मतलब देना नहीं चाहिए. अच्छा हम लोग तो because we find कि liver issues है, then we give it.
So because in the acute stages of gallbladder infection or inflammation, the wall is thickened and friable. We can see it on ultrasound also. So in that case, I think we should not give
Before
it.
starting it, we should do an ultrasound. This is very, very important. And anything कि indirect bilirubin बड़ा है, direct bilirubin बड़ा है, वहाँ से कोई क्यों निकाल सकते हैं?
Sir, मतलब I searched all the sources and I was able to find out.
तो direct का पड़ेगा, indirect का पड़ेगा.
Sir, in obstructive cases, indirect bilirubin is increased.
Direct.
Direct, sir.
वो से क्या?
Obstruction.
So direct generally will increase the obstruction. हाँ. Indirect में तो जब मान लो कोई hemolysis हो रहा है ना, आपका microcytic है ना, anemias है, जब आपके कहीं spleen में aggregation हो गया है red blood cells का, तब हम लोग कहते हैं कि indirect बढ़ जाए, ऐसे ही. So ये then this will work. Then direct hemoglobin is increased. Even we rule out those contradictions. This is interesting. We have used it in second. Indirect to liver pathology से बढ़ता है. People ये पढ़ा because then we can't blindly start it. Because we तो उनका hemoglobin देखते हैं में बड़ा है शुरू कर. The contradictions which he has shared, patient might land in more trouble than we will not be able to track that patient because patient को ना चले जाएगा. वो कहेंगे देखो जी उनको पता ही नहीं है. कभी-कभी bile ducts में आपकी cholestasis हो रहा है, वो तो आपकी normal exercise नहीं है तो उसके लिए फिर ये
contrast MRCP, yes.
नहीं आता है. हाँ वो सब करना पड़ेगा. डाइज डालनी पड़ेगी. एक बार contradiction दोबारा जा. Sorry, I couldn't attend. I wanted to attend this Metadoxin. So how it works? How it works? Because we do give it an alcohol liver disease, we do give it the fatty liver, people alcohol hepato, what do you call it? Non-alcoholic, FLD, fatty liver disease. So, and what dosages do you take? BD. Generally, यहाँ पे जो हम देखते हैं उसको कितना मिलेगा? Generally, many centers will only get isolated amounts. ये जो हेप्टिन sachets होते हैं उनमें कितना होता है? हेप्टिन में तो है, but it is not in big way. तो हम लोग कहते हैं ये problem है इसलिए we should not give anything which doesn't have Metadoxin. Metadoxin की ऐसे कोई contradictions है? कॉन्ट्रडिक्शंस नहीं ले सकते क्या होता है कैसे रिएक्शन हो जाएगा नहीं तो वो एल्डिहाइड डिहाइड्रोजनेज को क्या करते हैं अल्कोहल हाउ दिस मेटाबोलाइज अल्कोहल डिहाइड्रोजनेज will like to create aldehyde and aldehyde dehydrogenase give you an acid ऐसे ही होता है तो ये जो डाइसल्फाइड रिएक्शन क्या होता है which is more harmful accumulation of alcohol is harmful aldehyde is harmful or acid is harmful form में जैसे बनता लास्ट aldehyde is harmful so ये डाइसल्फाइड रिएक्शन में क्या होता है aldehyde dehydrogenase is elevated and the levels increase ये क्या करता है आपने एंजाइम का नाम बोला था ना मेटाडॉक्सिन inhibits which enzyme aldehyde dehydrogenase or alcohol dehydrogenase आपने भी प्रेजेंट किया हाँ कौन सा करता है एसिटाइल डिहाइड्रोजनेज को इनहिबिट करता है so does it has disulfiram like action the elder can explain it should not be taken with alcohol why it is important because a lot of patients are taking reactin and they are taking alcohol also can you check this point and tell us this will be because we know this is check करके जो दोबारा बताएं ठीक है आपको साइकेट्री में भी उसका यूज बताना था क्या जैसे so who is moderated your session तो साइकेट्री वाला इंटरफेस नहीं कर पाया हार्ट ब्लॉक्स आर इंपॉर्टेंट should know should also pick up कौन सी साइकोट्रोपीज हमें अवॉइड करनी है पेशेंट नोन पेशेंट ऑफ your type 2 heart block comes to you is a known case comes to you with bipolar disorder or epilepsy कौन से एंटीएपिलेप्टिक्स आप नहीं दोगे कौन से एंटीडिप्रेसेंट्स आप नहीं दोगे जो कंडक्शन डिफेक्ट्स कराएंगे वो सब वो सारे एजेंट्स नहीं देते ये तो कंडक्शन डिफेक्ट्स के तो लेवल्स हैं तो कोई भी कंडक्शन डिफेक्ट कोई भी साइकोट्रोपिक नहीं कराएगा तो नहीं देंगे इट इज वेरी इंपॉर्टेंट when I was at Dr. Shali's she has joined when I was SR I joined I just get upstairs medicine to see a case of bipolar disorder the lady was having drop beats and was on oxygen support and was breathless and very critical so I just saw that she was being given carbamazepine as a mood stabilizer then we know carbamazepine is a class 1A anti-arrhythmic drug so class 1A anti-arrhythmic drugs have a property of causing conduction defects they are not supposed to be given in heart blocks then we substitute with valproate in 3 days she was fine so and they were actually clueless because nothing was improved they were planning for pacemaker or something of that kind of thing so that is important कि हम वो दवाइयां ना any other drug which you know which has class 1A anti-arrhythmic which can promote these conduction defects so patient जिसमें भी speeds आ रही हैं bradyarrhythmias हैं pulse rate कम है तो आप ये सब drugs नहीं देंगे so one is कम हो सकता है हाँ तो दे देंगे तो चलो अच्छा है लेकिन दे देंगे we are not talking about QTC prolongation QTC prolongation that too it is very controversial because some people say it's very safe some people say it's not safe controversial some schools कुछ कहते हैं schools कुछ कहते हैं the overall QTC prolongation parental antipsychotics have to be avoided and it would all be low dose with this so हाँ चलो बढ़िया है चलो इसमें हम क्या करेंगे हाँ वो हमारे साइकेट्रिस्ट से अलग हो गया psychotropics so TCS all TCS should avoid it all TCS have class 1A anti-arrhythmic properties they can cause conduction defects so आप देखेंगे तो बहुत सारे कार्डियोलॉजिस्ट ही सैड ट्रिप्टो लिखते हैं without knowing it it can exacerbate their own patients so that is why this licensing becomes very important these topics are very important तो आपको ठीक है हाँ क्या देखा उल्टा हो गया, उल्टा हो गया, वो तो उल्टा इसको मदद कर देगा। पेशेंट जो उससे परेशान हो रहा होगा, तो एल्डिहाइड जो एक्यूमुलेट है उसको भी वो ठीक कर देगा। इसको ये फेवरेबल होगा। This activity is not disappear like ठीक है। हाँ वही पूछना, कॉन्ट्रा इंडिकेटेड है या ऐसे नहीं देना। कोई भी दवाई को बोल देंगे ना कि अल्कोहल मत लीजिए, उस तरह से होगा। कॉन्ट्रा इंडिकेशन तो नहीं लिखा, कॉन्ट्राडिक्शन तो नहीं है। ठीक, तो ये पीसीएस आप नहीं देंगे, कार्बोजपिन नहीं देंगे। कुछ एंटी एपिलेप्टिक्स हैं which they are saying the glycosamide, pregabalin, which you have to avoid in conduction defects. You can exaggerate those conditions. This becomes important. Okay. Okay. ठीक है, we'll felicitate. Ask the seniors of the So I think you all presented well. आपका नाम? Anurag has presented very well. Presented in your presentation content was of standard, and this you couldn't settle for very easily available materials. Yeah, the content was very rich, so I would like to congratulate you. आपका नाम मैम? Dr. Aparna, you were very good with basics, made things clear. These psychiatrists are not very cardiology से what करते, made very easy that what is type 1, type 2, type 3 thoughts. Congratulations. And आपका मैंने सुना नहीं है, but I think you must have presented well. And all the best for your future. Country is in safe hands. We couldn't present at your stage at such a good level. Okay, so हम लोग जिनका लेवल प्रोफाइल थोड़ा सा वीक रहता है, स्किज़ोफ्रेनिया वाले है ना, जिनमें मेजर एंजाइम्स थोड़े बड़े हैं, कैन ट्राई दिस ursodeoxycholic acid for a quick trial. What is it? हाँ हो सकती है, और पर बहुत ज्यादा पेशेंट्स नहीं आते इनके लेवल एंजाइम्स डिलीट, जनरली कोई ना कोई और मॉर्बिडिटी या कुछ और पेशेंट्स होते हैं। चलो जाओ स्टार्ट करते हैं।